technique, total edge intrusion for vertical control, advancing facial aesthetics and oral health by Professor Jun Jung Choi. The BAT technique, optimal aligner and TAD combinations for aesthetic and effective orthodontic treatment by Professor Benedict Wims.
Sau đây tôi xin trân trọng được chào mừng và kính giới thiệu chủ tọa của phiên khoa học hôm nay, giáo sư Takashi Uno và tiến sĩ Nguyễn Thanh Huyền. Trân trọng kính mời chủ tọa đoàn điều hành phiên khoa học.
Now it is my pleasure to welcome and introduce today's session chairpersons, Professor Takashi Ono, Dr. Nguyễn Thanh Huyền. With that, I invite our chairpersons to begin the scientific session.
Dear Professor Lu Chong-Trey, so please go to the topic, total arch intrusion or vertical control, advancing facial aesthetics and oral health. She is the professor in the Department of Orthodontics at Yonsei University College of Dentistry. She was the Vice Dean of Student Affairs and was promoted to full profession in 2021. Dr. Choi is an active member of multiple professional organizations, including the Korean Association of Orthodontists, American Association of Orthodontists, and the Korean Dental Medicine Society. She also serves as associate editor for the Korean Journal of Orthodontics. Her clinical specialties include temporal mandibular joint related malocclusion, anterior open bite, and growth modification. So this stage is yours.
Thank you for the kind introduction. Good afternoon, doctors. It's my great honor to be here to share with you my clinical experiences and research for vertical control. Please let me introduce myself. My name is Yoon Jung Choi from Yonsei University, Seoul, Korea. I would like to express my sincere appreciation for the organizing committee for the wonderful conference and for inviting me to this precious event. This is Yonsei University in Seoul, Korea, which is a very beautiful school. And also it was established in about 1885, and still we try to lead the world orthodontics by putting a lot of effort to do research and clinics. I have nothing to I have no conflict of interest to declare. And this is a very famous diagram of the envelope of discrepancy. As we all know, the introduction of the screws, the diagram should be modified like this. Between the orthopedic approach and surgical intervention, there is a new diagram of the skeletal anchorage system, which means that we are expanding the envelope. In the sagittal direction, previously it should be an extraction case, but by using the distalization technique, we can treat this crowding without any premolar extraction. In a transverse dimension as well, we can put the mini screw on the palate and do the non-surgical expansion, which calls as marpe these days. And previously it should be like a surgical assisted RPE, but these days we did not try the surgical technique at first, but we tried to non-surgical marpe at the first place. And also, vertical dimension, we expanded the envelope. The severe arterial open bite case can be treated non-surgically. By treating the molars, we can correct the anterior open bite and lead to the counterclockwise rotation of the mandible. So today, I'd like to focus the vertical dimension in more detail. Let's get started with this patient. She is almost a 40-year-old female. She she had a chief complaint of anterior combine and lower anterior cavity. From the supplementary analysis, we confirmed that she had a skeletal class 2, hyperdivergent profile, and anterior combine. Based on our clinical experiences, we are aware that molar intrusion and subsequent counterclockwise rotation of the mandible can correct the anterior combine. Like this way. But it's already more than 20 years since the orthodontic mini screw has been introduced in orthodontic field. So now we need to make more precise and predictable plans. Based on our previous research, we can precisely calculate how much more line intrusion is required. For example, if we want to increase 5 millimeters of overbite, then you can calculate we need 2.6 millimeters of maxillary molar intrusion, which is very feasible range. 2.6 millimeters maxillary molar intrusion can be achieved in routine clinical practice. And also, we noticed that the center of mandibular rotation is located 17 millimeters below, 7.4 millimeters behind the condyle point. We assume that the center of mandibular rotation is located on the top of the mandible, which calls as condyle point. But in the real field, when we research the pattern of the mandibular rotation, we notice that the center of mandibular rotation is not located on the condyle point, but located this point, which is close to the auricular point. Let's get back to this patient. So we will do 2.6 millimeters of maxillary molar intrusion and expect the counterclockwise rotation will correct the anterior combine. She also had this type of problems. She had missing upper right premolar, she had a severe cavity on the upper left premolar, and she had a root blast on the lower left segment. We decided to extract the 2 teeth, which was almost hopeless. So finally, she had missing of teeth 1.5, 2.5, and 3.6. In our transverse dimension, we noticed that her intermolar width was a little bit narrower than the average value, which means that the posterior teeth has a crossbite because of the narrow maxillary width. Although she had a mild skeletal facial symmetry, she did not want to correct the facial symmetry in a surgical way. And we know that the correction of the facial symmetry non-surgically is quite complicated because if you do the asymmetrical molar intrusion on the left side, you may induce the mandible shifting to the left side, which is likely change the joint space. And also it can be a potential risk of TMD. So we did not try to correct the facial symmetry, but we tried to correct the transverse discrepancies. But a previous report told us that in a suture-separated subject, there was a significant trend toward the low amount of suture separation with older age groups. She is 40, almost 40 years old, so it's not likely separating her suture even with the marpet. So this is her final treatment plans. In vertical and sagittal dimension, we will do the molar intrusion to correct the anterior combine and to induce the counterclockwise rotation of the mandible. Also, it definitely improves the retrognathic profile. In a transverse dimension, we just align the teeth and differential amount of intrusion between buccal and lingual side to try to correct the transverse discrepancy, not trying to mark it in a 40-year-old female. But we have an extraction space on the lower arch, so we're gonna constrict the lower arch and make it consonant arch between upper and lower. In the dental dimension, we will close the space, then we can relieve the crowding, and also we can correct the dental midline deviation. So 4 months, we started molar intrusion. We did not bond any bronchage on the anterior teeth. If we did bond the anterior teeth, then it's likely to extrude the anterior teeth. Then it's not a good effect for her facial aesthetics. Molar intrusion is going on, so anterior open bite is slightly improved. About 11 months later, we can get an incisor overlap, and 14 months later, we can get enough incisor overlap. Then we can compare the 7 months of treatment and 14 months of treatment. Molar intrusion corrected the anterior open bite without any extrusion of the lower and upper anterior teeth. Let's check it from the superimposition. This is the initial cephalogram. During the molar intrusion, we can see the counterclockwise rotation of the mandible. 20 months, 28 months, we will go on the treatment, and now we can see the lower third molar was